Good evening, everyone, and welcome to another educational series of International Dermatology Education Foundation. Today, we have a very special and unique topic about beyond petrolatum, optimizing epidermal barrier repair with a semi-occlusive formulation. You know, I always discuss about the vehicle, the importance of the vehicle. The same way, it's how important is the epidermal barrier, the stratum corneum. Now, it's not anymore. We used to think that it was a bunch of dead cells. Now we know that that's not the case. And we're very lucky to have an expert on this, Dr. James Del Rosso, who is really very, very well known about talking about the stratum corneum and epidermal barrier. He's got a bunch of articles on this, and we're going to listen from him. But before we go there, I do want to thank our supporter tonight, Weißerdorf, that makers of Eucerin and Aquaphor that I think we are all familiar with. Those are legendary products. And before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select the phone call in the audio pane and dial-in information will be displayed. If you're having technical issues, please submit your question in the questions pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate if you could fill out this very short survey. Also, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Now, a couple of words before I go any forward about the International Dermatology Education Foundation. IDEF is a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And we started our mission long time before COVID in live programs, but during COVID, we had to switch to virtual programs. And as you can see, we have done several of those programs, not only in US, but also in Canada, Latin America, as well as Southeast Asia and Europe. So please stay up to date with the IDEF Education Series webinars at LinkedIn, at Facebook, as well as on Instagram. Also, please visit us at idefeducationseries.com to register and to find out more about our programs. So finally tonight, again, our topic is beyond petrolatum, optimizing epidermal barrier repair with a semi-occlusive formulation. Our guest is Dr. James Del Rosso, who's very well known worldwide, but especially on this topic on several articles and several posters. Thank you, Jim, and welcome. Please take it from here.
Thank you, Leon. It's certainly a pleasure to have the opportunity, and thank you for that kind introduction. I also have to recognize that Leon worked with me on many of these articles and initiatives. So we're a dynamic duo, Leon. I hope everybody agrees. So we're talking about beyond petrolatum, optimizing epidermal barrier repair with a semi-occlusive formulation. And I think one of the basic tenets is it's really important for us to recognize the importance of what the epidermal barrier, which is, there are several different barriers. We're typically talking about the permeability barrier, which has to do with maintaining a critical amount of moisture in the skin, but also the microbiome and the antimicrobial barrier, in addition to others. There's many different things which we'll get into. And we're going to be focusing on the value of a semi-occlusive formulation and what Aquaphor has brought to the table. It has been with us for a while. It continues to be widely used, and it's the track record of Aquaphor that supports that. So let's see if so this is what we're going to be talking about. We're going to go over Beiersdorf as a company. They've been with dermatology for several years, and in addition to developing products, they also do studies to support the products, and we'll be going through some of those to give us the clinical side, not just the basic science and formulation side. We'll discuss Aquaphor, skin barrier, structure, function, the dysfunctions that's involved, and how we get repair, the difference between an occlusive and semi-occlusive ointment, and why that's clinically relevant. What does it have to do with skin health? Then we'll talk about specifically lanolin alcohol, not lanolin per se, but specifically lanolin alcohol. And not all lanolin alcohols are created equal. In the case of Beiersdorf, they have put together a purification process that's essential for reducing allergenicity. We'll talk about that. Then we'll talk about Aquaphor healing ointment related to in-office procedure and minor wounds, and then looking at dry, cracked skin. So we have a packed agenda, so let's get started. So Beiersdorf, the company, and an overview about the company. So Beiersdorf was founded in Hamburg, Germany in 1882, and over time has developed many core brands in the United States and also around the world. In the United States, we're very familiar with Eucerin, Aquaphor, certainly Coppertone, Nivea, and some of the others. Some of these are more commonly recognized in other companies around the world, but they do have a commitment to developing new products, adding to the products they already have, modernizing them based on adding on certain additives or attributes to some of the existing products, creating new product lines, but really focused to accomplish something specific. And that's backed by over 1,700 studies with more than 44 international participants around the world in those studies. So there's very often a clinical study or some type of basic science, directed basic science study to support the formulation and the additives. They do have a 32,000 square foot state-of-the-art innovation center, which is in Florham Park, New Jersey. And there's a consumer sensory panel focus room and also a laboratory that's really focused on, looking at the quality and also getting feedback from the consumers in terms of how they feel about the product and getting hands-on with the product. There are 60 scientists there that are really looking at what's being developed. So it's not just all perception. There's reality of actually testing and looking into these different formulations. So let's get to Aquaphor and some of the key milestones. So Aquaphor comes from two words, aqua and phorios, which means bearer or carrier. So the purpose of Aquaphor is to be able to carry, but help the skin carry rather than lose water. Because the epidermis and the stratum corneum, there's a gradient, a functional gradient. The epidermis and the stratum corneum, even more specifically, requires a certain amount of water for the enzymes to function optimally. Remember, many of these are hydrolytic enzymes, hydro meaning water. You need a certain amount of water. And when that diminishes, the enzymes don't function right. So the integrity of the skin and the structure of the skin changes, and it's not at its optimum, both in its appearance and its function. It will often get very dry and brittle, like a dry ground. If you've ever seen a Texas drought, when it gets dry, it gets cracked. It can't be resilient. It doesn't have recoil, and there's no ability to handle a shearing force. So it gets very dry and fissured, and that's what the skin looks like. When you can actually see that with your eyes, it has been going on for a while. It's not a new development. So the whole idea of having Aquaphor is to be able to help combat that in a formulation that is different than Petrolatum alone. Aquaphor is part Petrolatum, but it's not completely Petrolatum, and there is a difference, and we're going to be getting into that. So this is just showing you the history of Aquaphor. And when you go back and you look at, the patent application in 1925, 1936, you start to see products being evolving. You see that in 1982, they then put it into a tube. There was a new design, and then they came to the concept of the healing ointment. And we see that being developed from 1990 to 1991, and then a more modernized packaging. So they've adapted the packaging to time, but it didn't get into a science fiction looking product. It still maintained its identity. but had a little bit more of a modernized look. And we'll get into some of the newer formulations. But there is some very good published data. There's a lot of data available from Beiersdorf on Aquaphor and some of their other brands. But we're looking at Journal of the American Academy of Dermatology and Journal of Drugs and Dermatology, both of which are peer-reviewed and indexed with some important studies. Then we're looking at the ointment and the body spray. So you now have a spray that can spray an ointment where you can get some areas that may be harder for people to reach, but it's still essentially the same as the ointment formulation. And then we're looking at the question about, lanolin and lanolin alcohols being contactants for allergic contact dermatitis, which certainly they can be, but specifically the fraction and how they purify the lanolin alcohol and how they reduce that allergenicity. I can't say it's absolutely zero, but it's negligible compared to other fractions of lanolin and lanolin alcohol. And then the balm stick. So they're always trying to stay with different ways of applying that may help patients in certain situations. Right? So now we're looking at the Aquaphor Healing Ointment. It's the #1 dermatologist recommended product for 6 conditions. So you're thinking about the hands and feet, people have dry cuticles and that creates a problem. It's certainly not something you want to look at cosmetically, but also the cuticle needs to be intact to protect the paronychial tissue. And then dry heels and dry feet are often bothersome, especially when they get cracked and fissured. They can also become symptomatic. Dry lips. Sometimes patients are lip lickers. Sometimes they're just dry from the environment or products that they're using. Dry cracked skin, we already talked about. And then wound care. Post in-office procedures where many are still using topical antibiotics, which really don't play a role there overall. It's very uncommon that you need a topical antibiotic for a superficial office procedure or a let's say post-laser or post-peel or or post-biopsy, because the patient's going to have allergic contact dermatitis from neomycin or bacitracin almost always compared to getting an infection, unless they're immunocompromised or it's in an area where they're highly prone to infection. So the day of utilizing antibiotic ointments in the era of the procedures, even after excisions with a closed wound, is not the standard of care anymore. It used to be, but it no longer is. And there's good literature to support that. And then minor wound care, scrapes, abrasions. So it's very important, and we're looking at 30 years of experience, 24 clinical studies, including 8 wound healing studies. So trying to get this to move along. Okay. Okay, so now we're looking at the stratum corneum, and it was typically called brick and mortar. So if you think about bricks and mortar, that's a solid brick wall structure. We could say that the bricks, which are the corneocytes, are solid, but the mortar is not. The mortar it's not fluid, but it's almost like peanut butter or something that is not solid, but it's thick enough because there's lipid there. There's an intercellular lipid membrane that keeps correcting itself, that has to maintain a structure, mostly ceramides, but also cholesterols and fatty acids that function to control the amount of transepidermal water loss. And the bricks provide the structural integrity. So there's also cornified envelopes and other functions to maintain the structural integrity. And there's a lot of processes going on to maintain the proper water balance. Different disease states, abnormalities occur, and that's why we see dysregulation, usually with dry skin or sometimes ichthyotic skin changes. So these are some of the components that have to do with the epidermal barrier. So filaggrin is a protein that's in the stratum corneum that functions to be broken down into natural moisturizing factor and to also provide structural integrity. So when the skin becomes deficient, or I should say the epidermis and the stratum corneum becomes deficient in water, you have breakdown of filaggrin to form natural moisturizing factor, which is mostly amino acids to maintain water in the skin. So that's the humectant of the skin, right? And in ichthyosis and atopic dermatitis, you can have filaggrin mutations. So the skin is not able to do that. Normal skin will help repair itself. Remember, our skin is repairing itself all the time. We take it for granted. But in certain disease states where there are dysfunctions, the skin is not able to do that. So that's why you typically see the skin disease changes, right? There are also changes in the claudins for the tight junctures that hold the skin together, also can contribute to chronic itch. And then there's lipid barrier dysfunctions. There may be ceramide deficiencies or enzymes that break down ceramide. So the functional ceramides have a certain length and a certain structure to them that has to do with the skin functioning normally. And when that's changed, that lipid layer is not able to retain water into the skin as effectively. And that can happen even if you have a reduction in fatty acids, free fatty acids, or cholesterols, right? Alcohols and determinants, chemically, they can increase transepidermal water loss by creating irritation. They can decrease the natural moisturizing in the skin. They can sometimes reduce the fatty acids. And then an elevation of the skin pH alters the microbiome. And you start to have impaired corneocyte adhesion and increased Staph aureus colonization as the pH becomes elevated. Also, in certain disease states like atopic dermatitis, you have increased colonization with Staph aureus due to different proteins being missing. You have certain antimicrobial peptides that are deficient. That's why in atopic patients we see more staphylococcal infections and pox virus infections. We see more molluscum, and then the increased permeability can have to do with antigens that are presenting within the skin, and increased inflammation. And when you have increased inflammation, you get increased transepidermal water loss. So there's a whole host of these barrier dysfunctions that can contribute. Sometimes the patient has one of them. Sometimes they can have a combination, which makes it more difficult for their skin to repair itself. Hence, the right cleanser and moisturizer provides the support that patients need to normalize their skin. Very important concepts, and the fundamentals are really critical to understand what's going on, the difference between normal skin and when the skin has a dysfunctional process. So normal skin has a barrier integrity, has a certain amount of homeostatic water loss that's easily replaced by the self-correction. But then when you have barrier impairment, you have more water being lost out of the skin. The skin develops more fissuring and cracking, and it's a lot easier for irritants and allergens and even microbes, right? My own personal observation is when patients have very dry skin, I see more numerous warts on skin that has barrier impairment than skin that does not. I don't have data on that. That's a personal observation. But the way I think about that is it's a portal of entry. How's it getting in? So now we're rebuilding the brick and mortar structure. So how do we create a good functional moisturizer? You can have all of these special additives, but if you don't have the foundation of the moisturizer, it's going to fall apart. So you have occlusives. The classic occlusive is petrolatum, but there are other additives that could be occlusive and different oils and things that you can add so that you don't have the thick, greasy, purely occlusive. You have something that can spread and have emolliency. But what the occlusive does is it maintains that ceramide content. It optimizes the enzyme reactions by retaining the moisture, and it's favorable for the normal microbiome of the skin, right? But it's really providing a barrier to block the water loss, right? Then you have emollients, which are added to allow the feel of the formulation, but also certain emollients can create some occlusivity. Certain emollients could add humectancy, and then support all of the things on the right, which when you don't have that, go awry, like transepidermal water loss increasing, or just not having the antimicrobial peptide balance, etc. And then humectants are very important. So you have a patient telling you that when I drink more water, how come my skin's still dry? Because the water's going in, it's getting into the bloodstream in the skin, and it's percolating into the skin, and it's evaporating right out. You have to have something that holds that water in the epidermis and the stratum corneum, and that's what a good humectant does. So that's why we utilize hyaluronic acids, we utilize glycerols, right? Because they will maintain a level in the stratum corneum over and above what filaggrin will produce with natural moisturizing factor, which might be deficient. And now that humectant holds the water in the skin. So it's holding it there. Any that's trying to get out could be blocked by the occlusive. And you have emollients that will add to some of those components, but allow the product to feel good on the skin. If the product doesn't feel good on the skin to that individual, the patients are not going to read up on all this and say, oh, I don't like the way it feels, but it has the perfect occlusives, emollients, and humectants. If it doesn't feel right to them, they're not going to use it. And then you have to maintain the acid mantle. If you create an alkaline formulation, it's going to damage that epidermal barrier, just like the old time soaps that didn't control for pH were extremely damaging to the skin, right? A true soap. So an acidic pH actually allows the skin to function, the enzymes to function properly, and helps to maintain the proper microbiome. It's very important if somebody brings in a formulation into your office to ask them what's the pH. And if they don't know, it's important that they find out. It needs to be in a reasonable range of acidity. Okay. So now let's look at occlusive versus semi-occlusive ointment. So the concept here is you want good occlusivity. But if you think about putting a layer of petrolatum, and the classic white petrolatum is Vaseline, but there are other formulations, there are generic formulations. It's pure white petrolatum. It forms a barrier on the skin, and it could be occlusive as long as it stays there, right? But its substantivity is going to be based on how long it could stay on the surface of the skin. And what will happen is, you ever see somebody that puts on too much or then puts a Band-Aid on over it, and they keep it on for a while in occlusive dressing? The skin becomes soggy, looking like it was left in a pool of water or a bathtub for 30 minutes, and then you pick up your hand and it's got this soggy appearance to it, because the water has been trapped and hasn't been allowed to leave. So if you get too much occlusivity and too much moisture, it can macerate the skin, and then it's not going to be optimal for healing. It will heal. Obviously, we know petrolatum does that. So let's look at characteristics of an occlusive ointment and a semi-occlusive ointment. So an occlusive ointment creates an impermeable barrier that impedes the transfer of water and also oxygen transfer. 100% petrolatum is a perfect example of that. Okay, let's go back. Okay, I'm not pressing it, so somebody's jumping the slides. If we can go back. Okay. And there's other things that can be added to create hydrophobic occlusivity. Semi-occlusive could involve petrolatum, but it also has other additives. You have panthenol, which has humectancy and also promotes skin healing. Glycerin, which is humectant. Bisabolol, which is a derivative of chamomile, also is a promoter of skin healing. And you can have partial petrolatum, but this will allow for the occlusivity you need, but also allow for some transfer of the water and the oxygen out to try to simulate a more physiologic level and reduce maceration. So this is the concept. Wound healing. We know patients often will like to leave it open because they want to see a scab, that thick strap that's on the surface. Yes, it will heal under that, but it's going to take longer. Wounds need moisture, but they don't necessarily need total occlusivity. So semi-occlusive petrolatum-based ointments with the dressing could maintain a protective environment to improve wound healing, but they're designed to try to prevent that over-maceration, which happens so often, okay? So now let's take a look at the video, right? Let's click it on here. Do we have the sound? Okay. We'll move on to the next slide. Just for the record, was everybody able to hear that video? Hello? So let's move on, okay? Now we're looking at how Aquaphor is not the same as pure white petrolatum, the branded petrolatum jelly or petroleum, white petrolatum. That's 100%. So Aquaphor is 41% petrolatum, and it has other additives, panthenol, glycerin, and lanolin alcohol. So the glycerin and the panthenol will add some humectancy, and the panthenol is also able to help barrier function and has been well known to promote healing. The formula is semi-occlusive. So there are differences between the two, right? Aquaphor is able to absorb 3 times its weight in natural secretions. So if there's a wound that's secreting, it can absorb that so it's not sitting there on the wound, okay? So this is talking about the components of Aquaphor. So it's not a pure petrolatum. It does have petrolatum. It's preservative-free, fragrance-free, hypoallergenic, and non-comedogenic. So yes, it is an ointment, but it can be used on the face, right? And some people do use it on the face when they get very dry skin. Let's say they're on isotretinoin or they just have a problem with dry skin. The fragrance-free and the preservative-free reduces the risk of contact dermatitis, and it's hypoallergenic, meaning that it's uncommon for it to induce an allergic contact dermatitis. So you look at the other components, lanolin alcohol helps to replenish lipids, right? And it defends against moisture loss. So it has the component of being able to retain moisture within the skin. Panthenol has a softening effect on the skin. It also binds water, so it creates humectancy. Bisabolol has been around for years. My guess is Cleopatra used it back in the day because she, was the elite and had the opportunity to use a lot of different things that had the best additives. They didn't know what they were doing back then. They didn't have the technology we have now, but they knew that it would keep the skin smooth, keep it from getting dry, and reduce irritation. And then glycerin is a well-established humectant. It binds water, it replenishes moisture reservoir. But you can say to yourself, why do we need so many humectants? If you put in a high concentration of glycerin so you could reduce the number of additives, over a certain concentration, it would be very greasy. It would be cosmetically unacceptable. Sometimes certain concentrations of additives can create more irritancy. So typically we're utilizing a combination approach of different ingredients so that we're getting a better formulation with less chance of irritation and making it more cosmetically acceptable. So this is 41% petrolatum. It provides enough humectancy, enough occlusivity, but has components that add humectancy and other characteristics, okay? So now we have another video, okay? Let's bring it up here.
For healing ointment, the semi-occlusive ointment binds much of the water and releases excess water from the surface. CeraVe and Vaseline, due to their occlusive properties, repel the water, showing no signs of absorption. Aquaphor healing ointment acts as a moisture regulator.
So essentially what that's showing you is what semi-occlusivity does to attempting to be more physiologic and allowing some transport of water and oxygen, as opposed to putting a full block on the surface, which basically traps beneath it on the surface of the skin and could lead to maceration. Also doesn't allow gaseous exchange like oxygen. So what about lanolin? Lanolin alcohol is an important subfraction, and it has actually been processed in a specific way for the lanolin alcohol in Aquaphor. It's rich in cholesterol, sterols, and long-chain fatty alcohols, which are the important fatty alcohols, the alcohols that are not drying and irritating, like ethanol, for example. They are occlusive emollients. They reduce transepidermal water loss and support barrier repair. Okay? There's a purification process that's different. So when they looked at positive patch tests with their Mercol L101, which is a standard test, and then you're looking at Eucerit HOLA, that's the lanolin alcohol purified version. That's an Aquaphor. You're seeing in testing, there's different these two different formulations for allergenicity, significantly lower in the fraction that's in Aquaphor. Here we go with the next slide. So now you're looking at the purification process. Lanolin is wool's wax. It's a complex mixture of several different components: waxes, fatty acids, alcohols, salts, and detergents. They treat it, saponify it, and put it through an extraction process. So they get rid of the wool wax acids, and then they go through a molecular distillation process, clean out what are essentially the impurities they do not want, and they get a subfraction of lanolin alcohol that contains what you're looking for: cholesterol, sterols, and fatty acids. And overall, with as much Aquaphor as is used, there's really very little report that there's any type of irritancy or allergenicity that comes out from the real world. You're looking at, just in the general collection of complaints from 2019 to 2023 that are reported to the company, over 142 million units sold. I wish that I had a complaint rate this low on Google or ZocDoc or wherever people, rate us. 0.00019%. That's extremely low. So this process really selects out a very favorable lanolin alcohol subfraction. So now we go further into a publication where there's three well-known dermatologists. Dr. Kircik's one of them, looking at allergic contact dermatitis utilizing a petrolatum ointment containing lanolin alcohol. So we're looking at Aquaphor here. Okay? And this is peer-reviewed index. So what did they do? They allowed patients in an open label study, 3 centers, that were 499 patients between the ages of 18 and 75 who underwent in-office surgical procedures. Could be on a variety of different areas. And they applied up to 3 times a day, but at least 1 time a day, Aquaphor healing ointment to the wound. And they were given a mild cleanser by the clinician. And at approximately 10 to 14 days after the procedure, they were clinically evaluated for erythema, itching, and pain on a 5-point scale. They were evaluated for evidence of infection, which could have been the extent of erythema, but also a purulent discharge, and then clinical signs of contact dermatitis. Yes, you're going to have redness after a procedure, but here you're looking at edema, vesiculation, bullae, weeping, where you're saying this is just not redness around a wound. This is allergic contact dermatitis, very likely. So now when we look at this, I wish this would move faster, but there we go. We're looking at what these clinicians evaluated. So the 499 recipients, you can see here that none of them had features of allergic contact dermatitis. None of them had a purulent discharge or infection. Pain, they did not report any pain. 1 out of 100 reported itching, and about 6% reported any significant erythema. So the sense was there was very well tolerated and no allergic contact dermatitis. So the belief here, based on what was collected before, what's collected from the real world and from this study, is that all lanolin alcohols are not created equal. Okay, there's no reported incidence of allergic contact dermatitis in Aquaphor healing ointment in multiple clinical and patch test studies. So it appears to be a negligible concern. So polling question number 1. We'll see what people answer. We'll see what people come up with. Okay, let's see what kind of responses we've gotten. Okay. So 100%. Hopefully the information that I presented made sense and people feel that there's minimal concern with the lanolin alcohol and they feel comfortable with the information. Right, next slide. Let's move on. So what about in-office procedures and minor wounds? Okay. So studies demonstrate that 100% petrolatum creates a barrier ointment which can restrict transepidermal water loss. But tool is a signal to the body to recognize that there's a problem. Semi-occlusivity does tend to promote ceramide synthesis, which is necessary for barrier recovery. So this is a publication. This was a supplement on wound care in 2011, which Dirk Elson and others were a big part of. And there was a study by Nate Truchman and his group out of Colorado Springs. Excellent researcher. I know Nate very well personally. And in the JAD in 2011, they did a study looking at the treatment of minor wounds from procedures, a comparison of 3 topical wound care ointments utilizing a laser wound model. And this is readily retrievable, peer-reviewed and indexed. So it was a pilot study where they're comparing Aquaphor healing ointment, Neosporin, and polysporin. So Neosporin has polymyxin, bacitracin, and neomycin. Polysporin has polysporin and bacitracin. Polymyxin and bacitracin. And then you have the Aquaphor healing ointment, right? And so males and females, 20 of them, with Fitzpatrick 1 through 3, because we wanted to be able to look for erythema. We wanted to see how much erythema. It was easier to see those changes on lighter skin. Double blind, 4 uniform circular laser wounds, 5 millimeters, penetrated to the dermis on the inner arm. And they applied all of these to each of the 3 wound sites, and 1 site was untreated. The wound was cleansed daily, and the treatments were applied 3 times a day for 18 days, and the wounds were covered until day 7 post-wounding. So before wounding, they evaluated at day 1, 4, 7, 11, 14, and 18 post-wounding. Clinical grading of erythema, edema, confluence where the epithelium was forming over the wound, crusting and scabbing. Tool was looked at, wound appearance was evaluated, photography was taken, and the subjects graded the appearance and the symptomatology, and any adverse events were reported. So it was a pretty significant drill down with the subjects involved. So what you're looking at up top at all those different time points, to the left, it's day 1, and then you have day 4, day 7, day 11, day 14, and day 18. And you're seeing the progression of the healing of the wound, right? Then you're seeing with neosporin, polysporin, and then the untreated site. So these were all done on the patient themselves. It wasn't like Aquaphor was done on one patient, Neosporin on another. So you're seeing that they healed in all cases, but the Aquaphor healing ointment showed the reduction in erythema and the epithelial confluence sooner. So I would say the Neosporin and the polysporin are akin to if you were using Petrolatum alone, because the antibiotics in there don't have any direct influence on what's happening with the epithelium. So you're seeing that the topical antibiotics, don't add anything. They do add the risk of contact dermatitis, but the Aquaphor provided the quickest healing overall. The others healed, but they took longer. The untreated, you don't even have full confluence by day 18. You see, so when you're looking at these individual components, the Aquaphor is the blue in the squares. It actually was the fastest over time and showed the greatest reduction in erythema, edema, and epithelial confluence was the fastest. So, and the belief is the semi-occlusivity and the additives make a difference. Now, the key takeaway is really is no reason to use antibiotics for the prevention of infection in essentially class 1 dermatologic wounds. Those are clean wounds in accordance with the guidelines of the Center for Disease Control, and that's also the standard in our literature. And the healing components that I went over were superior with the Aquaphor. Okay. So polling question number 2, based on the data presented, Aquaphor Healing Ointment would be my recommended post-procedural wound treatment brand, and you list the percentage of your patients where that would be true for. Okay, so we got 80 to 100%. So hopefully what I'm presenting is making sense to people and they feel confident with the data that's being presented. Let's move on. Okay. The next slide. So what about dry, cracked skin? We're coming into the final stretch here. So this is looking at Aquaphor on dry, cracked heels. And we see a lot of dry, cracked heels. Right? They could be in men, but very often in women, right? And this is something that's symptomatic and also is not very visually appealing. And so women go in and they get pumice stone treatments for it and a lot of things applied. Men can certainly too, but I see it very commonly as a complaint in women, especially in the summer when their feet are exposed. They get dry, cracked heels. And there had been other products in the past where they had special additives like ammonium lactate and also had the possibility of stinging and burning with some of those formulations. Aquaphor Healing Ointment alone, without doing anything else, has been shown to be very helpful for dry, cracked heels. So these were 47 men and women with moderate to severe dry heel. Use Aquaphor Healing Ointment once a day to both heels in the evening, covered by socks. And there are assessments done weekly out to day 28, right? And after 28 days of daily treatment, right? They were evaluated at week 4. Clinical grading for clinical signs like cracking, roughness, flaking. Corneometry to evaluate skin hydration. High magnification and regular magnification to see what the heels look like, and a subject rated questionnaire. So now we're looking at week 1 is the dark blue, week 2 is the middle blue, which is actually, the color is called periwinkle, and week 4 is, I surprised you with that one, didn't I? And then week 4 is the red color. And you're looking at the changes, which was statistically significant at 1 week in reduction of the clinical scores for all of those features. And you see a statistically significant improvement after the first week, but as the patients continue to use the product out to 4 weeks, that continues to improve for scaling, flaking, cracking, and roughness. You're talking about once a day in the evening, right? Okay. Now you're looking at the appearance, right? Close up of the heels, baseline week 1, and then you see another patient baseline in week 1. You see a significant difference. And when you look at the macro, you also see a significant difference within 1 week. About 9 out of 10 subjects reported improvement after 1 week of just using Aquaphor Healing Ointment. No special additive products and none of the products that can cause stinging and burning. And now we're looking at the hands. Okay, a lot of patients have dry hands, visible dryness on both hands. Once a day at night for 7 days, covered by a white cotton glove. So you're seeing here evaluated at day 1, day 3, day 5, and day 7. There's photography. There's moisturization criteria, looking at global assessments and questionnaires, and then clinical grading baseline and at day 7. And I don't know what just happened to the, if we could bring it back. Okay, there we are. Okay, I might have hit the wrong thing. Okay. It's definitely possible. And so this is what we're looking at. Here you're seeing after 1 night, the dryness visibly improves. So the Aquaphor Healing Ointment will create a visible improvement in the dryness, usually within 1 day to a few days. And then over time, you should get that increased moisturization. Remember, the palms and soles are thicker, so the moisturizer has more work to be able to keep moisture into the skin. And now you're seeing the skin hydration. This is corneometry. It measures electrical conductance. You want the number to go up because the greater the electrical conductance, the greater amount of water, because water conducts electricity. And here you're seeing within 1 week that the untreated hand didn't help. But in the treated hand, you can see here that there was 95% improvement at baseline, and it was statistically significant within 1 day, right? Increasing the hydration. So the Aquaphor Healing Ointment is something that we use for xerosis. We use for a variety of different situations. We went through some of that. But when you see dry, cracked skin, that it's really showing you this patient has a significant problem. It's clinically proven as a semi-occlusive ointment that can actually expedite healing, but also maintain moisture and maintain humectancy within the skin. You see visible improvement certainly within 1 week. You could see it on the hands, sometimes as early as in the day to a few days, and will provide long-lasting relief. Polling question number 3, and then we're just about done. We can open it up for some questions and answers. Will you recommend Aquaphor Healing Ointment for dry, cracked skin based on the evidence presented? So the answer? Do we have the answer? Polling question number 3, do we have the answer? Okay. This is a different question. We didn't see the answer to the other question. So let's see what the answer is here. I didn't see the answer come up to the other polling question. Okay. So do we have an answer for this one, Miko?
The previous one, nobody answered.
Okay, all right.
That's why. This one here, we're getting some answers.
That explains that, okay?
Yeah.
Right. Let's see what happens on this one. Has to do with post biopsies. Select one. Post chemical peels, post labor, post cryo, or all of the above. So post biopsies, about 24%. You know, two-thirds of the patients answer the others, and a small percentage for the others. So there's obviously applications that people feel comfortable with. Let's go on to the next slide. So that ends the program. Hopefully this provided you some valuable information. I'm going to bring back my esteemed colleague. Please submit your questions on the right-hand side. And Leon,
Thank you.
I'll let you handle the questions and answers, or any comments you want to make about anything.
Yes, thank you so much. That was really eye-opening. That was a great lecture. Actually, what I want to do before we go to the questions, Jim, Nico, can you put that question that did not get any answer back? Maybe we can discuss that, Jim. What do you think?
Sure, that's fine.
Since nobody answered it.
Okay,
Was it this one?
for the dry, cracked skin.
That is correct. This is the question that was not answered.
So that's why
Thanks,
it says
Nico.
0 on the right, because nobody answered it, right?
Yeah. So this is Aquaphor Healing Ointment for dry, cracked skin.
Right. So when I think of dry, cracked skin, it could certainly be used for xerosis and atopic patients, and some patients like ointment based, some like lotions and creams. I get that. Sometimes patients that have severe xerosis on their face from something like isotretinoin, this is often helpful in those people. But these are
older
people,
patients with the legs,
right,
you know, with the asiatic
right.
eczema.
especially with the spray of that Aquaphor ointment.
Yeah.
They could spray it on the legs a lot more easily, right? They don't have to be rubbing it on. They may have to rub it in, but the application part becomes easier.
Yeah.
We have that. But I think what you're looking at here, the real dry cracked skin, I should say that one that's very apparent, I call that end stage xerosis. That's been going on for so long that the skin is just so dry and cracked. It's going to take a lot of work to undo that because it's taken a lot of time to get there. So that's pretty much the way I look at it. And Aquaphor provides a lot of help in those situations.
Yeah, exactly. I mean, I use it all the time on my heels, especially wintertime. I
So
love them.
the world now knows that Leon Kircik has dry, cracked heels, right?
You know what? Who doesn't have it, by the way?
Yeah, it's true.
Almost everybody has it.
Leon is opening his heart to the world on his
Exactly.
kid, right?
It's my own patient experience. How is
Right, exactly. You're right.
So, we did talk a little bit now, and then you did mention it, but just overall, what do you think what makes Aquaphor Healing Ointment unique?
Well, I think the semi-occlusivity is a distinguishing feature. In the beginning, years ago, I didn't necessarily know the difference when I didn't know a lot about it. I thought it was another brand of a Petrolatum because it looks like Petrolatum, but it's not. It's actually not as greasy to the feel, and it has these other attributes. And what it adds in trying to also restore the ceramides, not just provide occlusivity, and prevent maceration, I think is very important. It does distinguish it. Find out for yourself if you've not been using it and see if it makes a difference in your comparison.
Now, let's get back to the lanolin alcohol story, right? The competition made that a big story, and you did a really good job explaining that purification process. I really like those slides, and I was, by the way, part of that study that I did with Dr. Zoe Drelios and Dr.
Regal.
Daryl Regal. And there were 500 patients, and one of them was mine, who did have a little bit of secondary infection that looked like irritation. We weren't sure, so we took that out just to make the data really clean. And we had 499 patients. And, so we still have some bad habits. I recently stopped using topical antibiotics after the biopsies, right? And I think using topical antibiotics is going to increase not only contact dermatitis, especially to polysporin, but also it's going to increase antibiotic resistance. So how do you feel about using Aquaphor Healing Ointment for post-biopsies, post-excisions, basically post-procedures?
Well, I think a lot of people are utilizing Petrolatum instead of topical antibiotics. And there's been a lot of work on that to show that topical antibiotics, when you get that phone call that it's turned red and it's itchy, and if you bring them in, 99.9% of the time it's allergic contact dermatitis, honestly. And there's data to show it's maybe not exact, it's like 98%, whatever. And so the topical antibiotic is creating problems. And the data that actually looked at infections showed it didn't improve or reduce infections, but in sometimes because of the antibiotics, colonize gram-negative skin infections more often. And so it really doesn't help to have that there. And then if you're comparing the semi-occlusive versus the sort of more potential for maceration, you can try to tell people just put a thin layer on, but they gob it on, right? And that becomes more of a problem with Petrolatum. It gets too macerated. And when it's macerated and it's all white, it looks like your hand does if it sits in the water for too long, the wound doesn't heal as quickly, right? So I think the Aquaphor provides those advantages. And I didn't necessarily know that in the beginning until I started seeing it myself after seeing the data. Right?
Exactly. Well, it's 8 p.m. Time flies by when you're having fun with Dr. Del Rosso. So I thank you so much for that eye-opening lecture. I learned a lot. I still remember the old things coming back. So that was great. Thank you so much. I hope all of our audience learned a lot. And I do want to thank our supporter tonight, Barzerdov, makers of Yusri and Aquaphor, for creating this program. Now that we're done with their program, I'd like to invite all our audience for the next program, which is going to be November the 5th on Tuesday night at 7 p.m. We have Dr. Jennifer Song. She's going to tell us all about an oral treatment for severe alopecia areata. And I promise you that I will be more exciting. This session will be more exciting than the TV program that night.
Okay.
I'll thank you.
Oh,
thank you.
That's on election day.
That's election day. Yes.
Oh man,
Exactly.
it's going to be a lot of blabber on every TV station. Just give me the result. I don't want to hear the blabber.
Exactly.
Right.
But Jennifer Sunk will give the results.
Yes, she will. Yes, she will. Thank you, Leon. I'm glad you thought I was fun
Take
as
care.
well as educational. Thank you.
Thank you. Good night, everyone. Bye-bye.
Good night.